Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy. So we've been doing this session now for, this is the third session. I started putting this on and I call it kind of like an oral surgery fight club because the best practice for the oral boards is really just practice. And it's sort of unlike any other test we had taken before. And I was kind of miffed that the only way to study for it is really either go to an expensive course or try to set this up yourself. And anyway, having a big study group is super helpful, as is listening to the audio of some of these cases. So I'm I have plans. I keep procrastinating to put this audio up on Spotify or Apple so you can listen in the car and, whatever else. We had a study group last session, and I think out of our 15-person group, everybody passed, including Sean and myself and Tarek and everybody else, and Saltman too. Anyway, today I sent you guys a link to the sign-up sheet. Let me share my screen here because it's pretty useful. So I put together a little timeline here. I know it's only once a week. Right now, Sundays at 9 a.m. If you guys want to have something different, I think we also had another set. We used to have like 2 sessions a week. That's what our plan was back for like the group who took it in August. But once a week is more than fine. I highly recommend setting up to become signing up, to be an examiner and an examinee, because it gets you good practice in both seats. And I think Colin and Greg are pretty accustomed to this drill already because you guys ran it like Friday mornings during education and stuff. But anyway, you walk through a 12-minute case. It's really not, it's not terrible. They can only get into so much in 12 minutes. Like, they're not going to get into, what are the cellular mechanisms of how telomeres degenerate or something like that. If you're getting questions like that, you're in a pretty good spot. And then as long as you practice, I had a little tactic of making sound bites, which were little flashcards that I just load up into my mind, like diabetes, myasthenia gravis, Duchenne's, malignant hyperthermia, dosing on medications and stuff. I got to share my screen so we can get this first case up. This one's going to be for you primarily, Colin. I think you signed up.
Yeah, I'll do it.
Yeah, Colin, I think this one's going to be,
you know how to turn this
a little more complicated than what, right? Yeah. It's going to be, I already know, orthognathics pretty well. So I think it's going to be kind of interesting. Yeah. There's a curveball in this one. Let me share my screen here. New share. I'm going to share this guy. And we'll get everything going here. Let me see. It's an orthognathic case. So again, I told you guys about practicing loading up sound bites is a good way to take some of the mental stress off on test day. Like, you don't want to be thinking about how to classify diabetes or how it's diagnosed or, what a Warthin's tumor is. Like, that stuff should roll off your tongue as far as like diagnosis, criteria, demographics, signs, symptoms, how you treat it. That's a basic blueprint of a lot of these things. So I encourage you, like, on your own, to just load up a 1 to 2 sentence thing on all the entities you come across. But let's see. Can you guys see this screen now? At least hopefully Colin can see it.
Yeah, I got it.
Yeah. All right. So let me play this and we'll go from there. Okay. So You get let's see what time it is. It's 9:08. All right. So you get a 20-year-old female that comes in with chief complaint. I want a better bite, and my orthodontist says he can't fix me.
All right. So first thing I want to do is kind of get a history of her HPI. So has she had orthodontics in the past? Is this something that she's always been struggling with, or is it something new?
She really hasn't had too much ortho in the past. It's just been going slowly, but the orthodontist hasn't committed to one time frame or another. She says she doesn't really have any medical problems, no allergies, nothing else. What's in your physical exam for this patient?
So starting with physical exam, I'm just going to start with an overall kind of visual examination of the patient, looking for any asymmetries, going through my landmarks or my facial third. So upper third from tracheon to glabella, glabella to subnasale, subnasale to menton. Based on her photo, it looks like she's definitely long in the lower third. I'm also doing vertical fifths at the same time, which hers look a little bit reasonable. Her nose is a little wider than her medial canthus. And
what
then
kind of
after,
what kind of would you call this a skeletal or a dental discrepancy?
this is most certainly a skeletal malocclusion that she has.
What class malocclusion does she have?
So this is a severe class 3 malocclusion. So she has, looking from her profile view, I think she has a combination of maxillary hypoplasia with a definitely a significant mandibular hyperplasia.
What would be additional studies or
so I'd like to just get a
imaging you want?
Panorex for a screening exam first.
Cool. So you get a pano, you get a cone beam as well. What goes into your pre-operative planning for this?
So for her, I'm going to have a lengthy discussion as to the indications for surgery. In her case, obviously, an improvement in function is at the top of the list. After that, I tell her that she can expect some aesthetic changes, although it's not solely an aesthetic surgery. There are aesthetic components to the surgery as well. As far as workup, we do this all, or I do it with virtual surgical planning. So I'll need 2 sets of models or an intraoral scan to be able to submit to the virtual surgical planning team, along with a cone beam CT with her in centric relation.
I understand. So you get your virtual surgical plan, you set that just fine. Let's say you've gotten to the operating room or, on the day of surgery. How are you preparing for this case, and what are you telling the anesthesia team?
So first of all, with the anesthesia team, I want to give them an idea of how long the case is going to be. So typically a double jaw surgery is going to be between 3 and 5 hours. So I would have them prepare for a nasal tracheal intubation for her. I let them know about hypotensive anesthesia about an hour into the case. So they may want an A-line or something if they want to monitor more closely with that.
Sure. So you have
Foley catheter.
You have the patient prepped and draped on the table. Can you walk through your surgical procedure?
Yeah. So for double jaw, I start with the mandible. So, well, before starting, I would place a K-wire in the radix for a vertical reference mark. Make some measurements. I make any tooth adjustments as determined by the plan. I try my guides in, make sure they all fit. After anesthetizing, I would start with the mandible. Like I said, I'll make a vestibular incision in the posterior mandible on the lateral of the external oblique ridge from the second, between the first and second molar up the ascending ramus. I dissect through mucosa and muscle down to periosteum. I raise a full thickness periosteal flap up the ascending ramus.
I understand. So you get up to the maxilla and you're completing your osteotomies up there. What's the order of your osteotomies in the maxilla?
So my maxilla, I start with from the lateral buttress across to the lateral nasal wall. Once that's complete, I do a lateral nasal osteotomy with a guarded osteotome and then a double-ended osteotome to separate the nasal septum. After those are complete, I proceed to the pterygoid plates using a curved osteotome angled inferiorly and medially um, to
Sure.
complete the
As you're scoring the posterior sinus wall, the maxilla, the whole mouth starts welling up with blood.
Mhm.
What do you want to do?
So first thing I want to, this is before I've down fractured.
Yeah.
So first thing I want to do is place some afferent soaked pledgets in the posterior with maybe some Surgicel.
Sure. It kind of keeps bleeding. Can't really.
So I'm going to
really
complete
see
my
where
down
it's bleeding.
fracture and try to visualize where the bleed's coming from.
Sure. So you complete the down fracture, you're able to see the vessel. What are you going to do?
If it's the descending palatine artery, this is a vessel that I normally sacrifice. So I either use, if I can visualize it intact and get a clean cut, I'll use just bovie electric cautery to come through it. If not, I may use
what's the arterial supply to the maxilla once it's down fractured?
Once it's down fractured, it's really from the palate, from the ascending pharyngeal, from the palate.
Sure. So you complete your down fracture, everything goes just fine. You end up ligating that artery, and the rest of the surgery is pretty unremarkable. In PACU, and later, well, about 2 hours after surgery, your intern notices that her lips and gingiva look a little dusky.
Mm-hmm. So I'm concerned for a little bit of necrosis or avascular necrosis of the maxilla. At this point, I would examine the patient and kind of do a capillary refill test and see what I feel like the perfusion to the teeth are.
Sure. So about, this goes on about 48 hours out. The exam hasn't changed. What do you want to do at this point? This is kind of, this is what you're seeing about now. It's 2 to 3 days out.
Yeah, unfortunately at this point, there isn't really a whole lot surgically I can do. So for her, I would definitely probably lean towards trying hyperbaric oxygen.
Sure. Yeah. So you try around, 20 dives of that over the next, 2 weeks, and it really doesn't get better. Just just foul smell in the mouth, and cap refill isn't any better.
Yeah. So I would proceed with doing a debridement of some of this dead tissue, and see if I can get down to any healthy tissue.
Sure.
Surgically.
So you end up taking her back to the operating room for debridement of surgical tissue, or necrotic tissue. Ends up, most of the maxilla is pretty necrotic.
Yeah.
Is there, would you have prepared the patient for anything additional before going into this, or can you prepare the patient for any reconstruction?
Yeah.
Now that this has happened?
Well, obviously in this case, we're going to need a vascularized free flap to reconstruct this area. For this extent, I would probably lean towards a fibula to complete this reconstruction. Prior to the surgery, I definitely would have told the patient that about what was happening in the necrotic tissue, and it could extend to bone. Unfortunately, this is pretty extensive, so I think she's going to need a free flap.
Sure. So what would be your choice of flap?
Like I said, I think we're going to need both hard and soft tissue for this reconstruction. So I think a fibula is a really good option for this.
Okay, the patient goes ahead according to that plan. You end up inserting the fibula using a pre-milled and pre-milled plate, and that all goes according to plan. At what time are you going to consider placing implants for this patient?
So I guess there's kind of two trains of thought. One would be if it was done with virtual surgical planning, the potential to do implants at the time of reconstruction and let them integrate. Or in this case, we had the vascular necrosis. I probably would go a different way, a more conservative option, wait until I was confident my flap had survived, in which case I would probably wait at least 6 months before placing implants.
Sure. So which choice would you be making?
So I would wait 6 months.
Sure. So that all goes according to plan. I mean, that's the case. That's the case. And that was a full, like, what time did we start? We started 9:08, something like that.
Yeah.
I mean, that was already a full 12 minutes right there. And that one got, a little hairy. I kind of sped you along. You did really well in that one. I mean,
it's a lot different rather than just listening.
I know. It's a lot different. It's a lot different. Just getting the words out.
My mind's going in a million different directions. Like,
I know.
Stay on track.
Yeah. And it's just a good exercise. Like I kind of have fun leading these because it is like, it's a new thing, just articulating it and going through it and putting yourself in the situation. Like, I think we all know the answers to this sort of thing, or what, if it were a multiple choice bubble on a test, it's, it's one thing, but, I mean, right from the get-go, you had everything, like your HPI, getting into, has she had ortho before? Any pre-existing conditions, med history, allergies, all that. That's automatic. And then you jumped right into the exam. That's perfect. I thought what you did to describe what she had, like for an orthognathic case, breaking it down into thirds and, midlines, tooth show at repose, and Andrew's judgment. And then like what, if there's a maxillary cant, if she's class 2, class 3, does she have her third molars in? That was actually one thing I kind of forgot about till just now. And I forgot how long to leave third molar, or to take third molars before the case. Is it 9 months?
6 to 9. Yeah.
6 to 9. So that's another thing to look out for. But yeah, you diagnosed all that correctly. And then, walking through the surgical plan. If you're trying to think on, and I know Colin and Greg and Gene, I know you guys all have like awesome orthognathic experience. Do you guys get thinking? Yeah.
For these types of cases, I was like, I actually just take a premolar out on the bottom, or take out 2 premolars and just cement a mandible.
Yeah.
I feel like all that stuff though is like they would go along, right? Or if they'd be like, if they're trying to lead you to this complication of like the maxilla not having blood supply, then I'd be like, well, what if you don't want to do that?
Yeah.
Then
there's a bunch of different ways it can go. That's a valid thing. If they start talking about like a
I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord. And I'm his protege, I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go, ooh, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.